let's turn on to aortic valve. Okay, so I'm going to tackle aortic stenosis. And I think to put you in the zone, in the mood for an aortic valve, this is the aortic valve here. It's a nice, normal trileaflet, 3 cusps. And then this is your bicuspid valve, right, which presents usually with aortic stenosis at an earlier age, although at times it could be quite late in age that you see it with some calcifications. This is rheumatic etiology. Well, for us, we don't see as many of those, but it can trick you in the echocardiography laboratory or any other laboratory because they're not as calcific. Most of the fusion is at the commissure level as opposed to the last one, which is the most common in this country, degenerative aortic valve, a lot of calcifications. By echocardiography or CT, MRI, you're not going to see much calcifications. So we have this disease, right? And for you, from a diagnostic point of view, in addition to the valve AHA and ACC guideline, this is the American Society update last year, basically, looking at a revisiting of and retweaking of the guidelines as to how do you evaluate an aortic stenosis. So from an imaging point of view, before you start talking about gradient and valve area, et cetera, take a look at what is going on in the valve itself. Are you dealing with an aortic stenosis or subvalvular aortic stenosis with a membrane or supravalvular disease? You need to find out where's either the murmur or the gradient coming from. Also, you look at what is the adaptation of the ventricle itself. Look at the hypertrophy here, what's ventricular function, systolic and diastolic, right? And therefore look at the various adaptations of hypertrophy, size, and function. What happens with a more and more severe aortic stenosis? What happens is, basically this is the same blood that is going through this valve. Acceleration of velocity occurs, so you can detect that with Doppler, and this is from an early depiction of this by Liv Hatley. She is the mother of echocardiography and Doppler. And you can take a look at what happens to the velocity. Normally is less than 2 meters per second going through the aortic valve during ejection. And ejection occurs in about 250, 300 milliseconds. So you're going to have to eject this blood rather quickly through the aortic valve. And as you have more and more severe aortic stenosis, the velocity increases over time, and we know how these relate to gradients. So how does it relate to gradient? By the simplified Bernoulli equation, which is 4v squared, if the v1 is rather small, which is usually 1 meters per second. So basically, the higher the velocity, the higher the gradient across the valve. Okay? So we got that. Now, the interesting thing is, if the flow is not normal, if the flow is reduced, either the ventricle is reduced in function or the ventricle is small, then you have lower flow aortic stenosis. The valve is still rather tight, but the gradient and the velocity is less than is expected. And this is where some of the nuances that you're going to read in the literature about low flow aortic stenosis, paradoxical low flow, and we're going to try to go through that at least for you to remember. And this is where, I know Dr. Perlmeyer talked about the continuity equation. This is actually the first application of the continuity equation, meaning that flow stays the same. And if I have a cross-sectional area, a certain cross-sectional area, and it gets smaller, like going through an aortic stenosis, velocity is going to increase. And this is the first application to derive a valve area from velocity before in the alveolar flow tract and velocity through by continuous wave Doppler. Okay? And this is a historic slide, I would say, because that was when I was in your shoes, fellow, 32 years ago or so. This was our first demonstration that you could do all this non-invasively. And nowadays, you're going to rely the vast majority of the time on echocardiography to give you that diagnosis. And if there are issues with that diagnosis, you go to other modalities. So how do we do this? Well, you look at the severity, you look at maximal velocity, gradient, mean gradient, valve area using the continuity equation, and also we look at the depiction of this aortic stenosis jet, similar to what you feel on your examination. If the stenosis is worse and worse, the maximal pulsation, the maximal velocity occurs late, so the gradient that you saw looks much more rounded. So these are the criteria. We integrate velocity, valve area, we have attention to methodology. We're not going to go to all the methodologies today. And considerations whenever you have low flow conditions, you want to make sure that this is indeed what you're dealing with. When is severe? If flow is normal, severity is bad, if your velocity is greater than 4 meters per second. So most of the time, if it accelerates almost 4 times, 1 meter goes to 4 meters or more, so 4-time almost acceleration is really bad aortic stenosis. And usually it is a mean gradient of 40. This 1 centimeter squared is a bit more generous. And what I'm saying, it's sensitive and not specific. And you're going to see some discrepancies in your life when you do that, because the relation of pressure gradient to valve area does not cut through 1 centimeter square. It cuts to closer to 0.8. So if you want numbers that kind of go together, 4 meters per second, 40 millimeters of mercury, a valve area close to 0.8. The closer you are to 0.8 or below, you're more confident that this is really severe aortic stenosis. So cutoffs, greater than 40, etc., specific, 1 centimeter squared, a little more sensitive. This is a case and example. This is not severe aortic stenosis. This is certainly moderate. Normal stroke volume of 70, mean gradient of 23, valve area 0.95. Early peaking of the jet itself, you see it here. This was actually a patient of mine several years ago. Ventricular function is good, fine. You follow them yearly, listen to them, exactly, right? And take a look at what happens over time. His stroke volume stayed about the same. However, velocity increased, the contour is different, and mean gradient increased over time till he started getting symptomatic. Valve area is tight, 0.7, time for surgery. Indeed, went to surgery. We have to take a look, and nowadays there are a lot of things in the literature. Also, we're seeing a lot of older individuals coming into the laboratories, into valve clinic. Hearts are usually smaller, much more calcifications, and therefore it's putting a stress a bit on the methodology of how do you evaluate that. And that's why this slide is very important. All these slides you're going to get on YouTube, so you don't have to follow every little word. Errors in calculations are important, because whenever you say low stroke volume, you want to make sure it is indeed low stroke volume. And this is one example for you going in imaging. Anyway, you're going to be exposed to imaging. If you have a hunk of calcium right here, this is really not your diameter to measure, right? You're going to have to either use another site for flow, because otherwise you're going to determine a flow that is really much smaller. And these calcifications are localized. They're not all around the annulus. And that's why you can get into trouble. So this is an individual who has a depressed ventricular function. You could see that this individual ventricular ejection fraction is low. If it's stopped playing, it was playing. You go up with the stroke volume as 45, peak velocity is low, yet the valve area is 0.7. When you get to these situations, then you're going to try to increase flow. And usually nowadays, I think most people will go for a dobutamine stress echocardiogram to try to improve contractile reserve, try to improve flow, and recalculate what your flow, what your gradient is, and what your valve area is. So that's what you're going to see in the guideline. Also, we don't push dobutamine to high doses. I think 15, 20 max certainly would be plenty, okay? And if you do that, you have different responses. You can have a stroke volume that increases, gradient that increases, and valve area stays the same, so you feel comfortable that this is truly severe aortic stenosis. On the other hand, you can increase stroke volume, but gradient doesn't increase at all, and valve area increases. Therefore, this valve is very dependent on flow, so AS is not severe. And you can have a third scenario where really this ventricle is so bad that you don't have any contractile reserve, and you have to use other means to figure this one out. So this is a case in point, 87 with all the comorbidities that you can think of, and this is this valve. Heart is depressed, valve is calcific, and you give it dobutamine echocardiogram, baseline EF is in the 30s, EF goes up a little more, and let's take a look at what really happens here. What happens is, this is your stroke volume at 45 goes up to 66, velocity at 2.7, look at how much increases at 4. So valve area stays really rather tight, I would say, 0.7, 0.8. So this is really severe aortic stenosis, low flow situation. This is another example, also a depressed ventricle. You could see the valve is calcific. It opens a little more maybe than the other person. And you do a dobutamine echocardiogram. EF improves from 20s to 30s. And let's see what happens to these. My goodness, stroke volume increases from 44 to 76. and peak velocity barely increases, so you know valve area increased significantly from 0.9 to 1.4. So this is an individual with milder form of aortic stenosis and a cardiomyopathy, as opposed to this being related. You hear in the literature paradoxical, low flow. Paradoxical, why? Because it's a low flow situation, yet you have a normal ejection fraction. So think, why do I have a lower stroke volume if the ventricular function systolic is good? It is a small ventricle, right? It's either a small ventricle or this output is going somewhere else, like significant mitral regurgitation. So this is a scenario of small ventricle, concentric remodeling of the ventricle because of hypertension, some other things, right ventricular failure, basically ending with a small LV. And you want to make sure that what you calculate makes sense. So in this situation, take a look at this heart. It's hypertrophied, but it's rather small. The left atrium is very large. And if I do the numbers, stroke volume is just 38. Valve area is 0.5. Is this real, right? Or am I underestimating? So what I do is I take a look at the ventricle itself and measure it. Ventricle is very small, 65 milliliter, without being indexed, right? So it makes sense, actually, that the stroke volume is low, that I feel much more comfortable that this is really a low flow situation. You can take a look at this is an editorial I wrote, trust, but verify that one. This is very important, right? Because otherwise, people are depending on you as an echocardiographer or an imager to make that diagnosis. So, in summary, increasingly important as a first-line modality for aortic stenosis assessment, particularly nowadays with catheter-based procedures. Attention to details for those of you going to the echo labs, that's, or even CT labs or MRI. This is very important for you to understand that in addition to the hemodynamics. It is a continuum. Don't take these numbers are so rigid. They're not going to fit all the time where they are. But think about that as a continuum. Low flow situation may be seen in a depressed or normal ventricle. And depressed EF needs to be repeated with higher flow, like dobutamine stress echo. When you have this low flow or paradoxical low flow, you want to make sure that these numbers really are making sense by looking at the ventricle and doing some other maybe site measurements. This is our team. You met quite a few of them already. Thank you very much, everyone.